Great to see everyone again. Great. Turn your cameras on. You can even wave hello.
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 Hello, Dr. Wen.
Hello, Josie. Good to see you. And that's Cheryl. That's good to see you. Who else is here? Lots of people here with their cameras off. And just scrolling through to see who else is here. All right, we'll give everybody a minute. They're all still logging on, connecting to audio. Okay, that's great. Fantastic. Oh, is Rosario raising their hand already? Did you want to say something? Okay. All right. So anyway, welcome again. And to our monthly Echo series. We're really excited that you're here. Next slide. As you know, we are doing especially for you, care home operators, get all your questions answered, learn from each other, free continuing education credits, and good expertise and consultation. So it's fantastic that you are all able to join us, especially since today we're sort of doing the wrap up for the depression series that we have. Next slide. I want to encourage everybody to share your cases or challenges, anything you are hesitant about. Just don't share your patient names or their birth dates or any other personal information. And your questions can be anonymous, and I will instruct you again a little bit later. But if you do have questions, and a lot of today is going to be your discussions, please, you can message them in the chat box. Message Juliana Caldwell in the text box, and then she'll read your questions without your name. So then you don't have to be embarrassed or anything. So we want it to be a safe learning experience. And yeah, so echo case discussions are not official doctor consults. This is really for teaching purposes only. Next slide. And as you know, there's a chat box there. Enter your name and anybody else in the room that's joining you today, that's part of our attendance. So I'm expecting this chat box to go crazy with lots of messages. I want you to practice typing in the chat box. That would be fantastic because we want to hear from you. And then there, a mute button, just make sure that if you want to speak, you gotta, unmute yourself. But keep it muted while we're talking so that we don't have lots of extra noise. Oh, hello. Everybody type into the chat box. We need some more chatting in there. Thank you. Okay, so this is the series we've had so far. We started in earlier this year, and we've just done, this is the fourth in the series on depression, recognizing depression, medical treatment for depression, addressing loneliness and depression. We talked about behavioral activation. And today is sort of that wrap up of the depression and behavioral health with lots of opportunity for case discussion and sharing. And then starting next month, we're going to start talking to patients about what matters to them in advanced care planning and things like that. So that's going to be another really great series. But yeah, next slide. So in order to, we are providing certificates of attendance, CMEs, and social work credits. And so if you do want credits, you have to register, which I know you guys have done, and complete an evaluation, which will be link will be posted at the end. And I know you guys know how to do that too. Next slide. Okay, so this is time for introductions. You know me already. Is Juanette around? I hope so. If you're around, Annette, say hello. And Maribel as well. Great. And then also, We have a couple of extra special guests today. We have Juliana from Aloha Care, service coordinator, but we also have Steve Falcon joining us. Steve Falcon, he is a behavioral health manager at Aloha Care, and he is here to, provide tips, answer any questions you have about behavioral health challenges. And so we are particularly lucky to have him today. And so I want you all to bug him. You want to, I don't know, can you share your camera, Steve, and wave hello? Is that possible?
Hello.
Hi. Steve Falcom, are you?
Sorry, I was muted again.
Oh,
Happy
okay.
to be here.
Okay,
I don't
great.
have a camera enabled on this particular
Okay.
laptop at this point, but I am here, and I'd like to say that Janelle is here as well with us today, and we're kind of in the background and ready to help any way we can.
Okay, fantastic. And we usually have Shane Anderson from United Healthcare, but he couldn't join us today. And then hopefully Lucas Morgan can join us again today as well. He is a clinical psychologist with Iola Lahui, and he has been assisting me with the slides as well. Okay, great. Next slide. Okay, so we made it out of the holiday season. How were the holidays for everyone? Was okay? I know a little bit different, kind of like last year, maybe even worse, but did you do anything for yourself this year? Did you treat yourself? I'm hoping you did something special.
Next week for sure. This week we just had Arizona Echo start. I'm going to go help manage that. But
You guys want to share? You can. Oh, spent the time working in the garden. Oh, yay. That is nice. I hope you spent some time with your family as well and doing a little bit of something to connect with those who love you and that you love and care about. So hoping that family time was refreshing and you got a good sense of support. Okay, next slide. Oh, somebody else had a family vacation. I see. That's fantastic. Family vacation is good too. Good. All right. And then also, I think the slide previous to that was, how was holidays for your residents? Did you do anything special with your residents? Anybody do anything special with the residents? Anything fun that can make us smile? Lots of caroling. Oh, good. Christmas carols and Christmas songs are really great. People, even with dementia, tend to remember those really deep memories, and they know, I mean, who doesn't know Jingle Bells, right? And that can bring out a lot of party. Okay. The residents had a party. Good, good. I'm glad you guys did something special. Dinner on Christmas Eve with their families. They had a chance. Yay. Probably hadn't for a long time. So hopefully was able to stay safe and not get COVID and still get to see their loved ones, party with families and clients. That's great. So everybody took advantage of that, right? No more isolation, but still try to remain safe and still get together. I'm glad for them. All right. You can keep chatting if you want. It's always good to see. All right, I'm going to go quickly over the COVID corner again and just give you some quick updates. Next slide. So yeah, just updated this one today. This is where we are with the Omicron variant. It began December 1st. And as you see, New York City went way sky high into a peak over there, like the Empire State Building. And then it's starting to drop, and you can see, so it's peaked and it's now coming down. US is actually coming down as well, but unfortunately Hawaii is still climbing up. We're not done yet. We're not quite at the peak. We usually lag by a couple of weeks, so I'm hoping that we will hit a peak soon and start to come down over the next couple of weeks. So I'm going to encourage everyone to just sit tight and stay safe because we're not quite done, or Omicron's not quite done with us yet. Next slide. Okay, and I'm going to continue to encourage boosting. You know, wearing a mask at all times protects against all variants, regardless of, you know, the shock or anything like that. Avoiding large gatherings, small gatherings, okay, but avoid those large gatherings. Get vaccinated and get a booster. Having that extra booster seems to make a big difference in terms of people being less sick when they get the COVID, which is really contagious. Getting a booster shot slows the spread and reduces the likelihood of new variants emerging as well. And because it's so, it's kind of a different bug, different virus, and people may not get really sick or as sick from it as the other variants. However, so if you feel even mildly sick, especially if you have just a sore throat or nothing else, please, you know, don't go to work and get tested. Get PCR test, antigen test, home self-test, anything. Just make sure you don't have COVID, because people have been fooled. They thought, oh, it's just allergies. I got a little stuffy nose and a sore throat, and that's all. No other dramatic signs or symptoms. Take it serious. Just get tested, because even if you don't get sick, you can pass it on to somebody else who will get super sick. Next slide. Okay, just a note on testing. If you haven't heard already, I guess the Biden administration has made these at-home rapid tests available. And if you go, you can go sign up for these for free test kits online. Just go to the United States Postal Service, USPS.com, and they will give you a little starter kit, so to speak. So like 4 per kit, and you can get it for free. The other thing that is new for the Biden administration is that insurers must pay up to 8 tests per covered individual per month. So yeah, so a family of 4 times 8 is 32. They could get 32 tests per month if possible, if needed. So that's good to know, so that if you get early symptoms, you can just stop right where you are and get tested before you start mingling with other people and getting together. Send patients. The other thing is you could just send patients for testing. You know, they have all these testing sites all over the place. You have to watch out. Some of them have antigen testing and others have PCR testing. So you just kind of have to find out which one it is. And if you're, just know that if your care home resident is at high risk and possibly eligible for treatment, outpatient treatment with pill or IV treatment with a monoclonal antibody, then they will want to get PCR testing to confirm it as a consideration for treatment. Also, if somebody tests positive, you need to make sure that you have a lot of the data down. You know, make sure to collect date and time of symptom onset, exposure details, whether you're wearing a mask, were you vaccinated, you know, who was the person, was they vaccinated or unvaccinated, and the people and the places you were in contact with from 2 days prior to symptom onset. So keep log, think about what happened the last 2 days, and that close contact is considered within 6 feet for more than 15 minutes, regardless of mask use. So over the last 24 hours. So 6 feet, more than 15 minutes, although Omicron apparently doesn't take 15 minutes, even less to spread. And that there are now, unlike last year, right now, we do have treatments available. We have an oral antiviral pill called Paxlovid, and that can reduce high-risk people from going to the hospital because they're really ill or even dying. and it's taken as a pill twice a day for 5 days. And you have to take it really soon, within 5 days of the symptoms start. There are also monoclonal antibodies to boost your immune system even more. And that's an IV drug that can also reduce hospitalization and death if taken within 10 days of onset. So there are a couple of other pills and IV drugs out there, but some of them are actually in quite limited supply. So we need to, I guess we need to check with the your doctor and the hospitals and the pharmacists, because there's not a huge supply. So they're trying to keep it, give it to those who are at highest risks at this time. Next. And just a note about isolation and quarantine. As a reminder, if you are having a scratchy throat and you went to get tested and you're a little bit concerned about whether or not you have COVID, isolate yourself while you're waiting for those tests. If you are COVID positive, however, you still need to isolate, even if you got vaccinated. Just because you got vaccinated doesn't mean that you're scot-free and you still got out. You're still contagious. So if you're COVID positive, regardless of vaccination status, regardless of mask use, you need to isolate, even if you feel well and you're not sick. That means in a separate room, no meals with others, avoid physical contact with people or even your pets. Do not share unwashed household items, personal items. If you have to be around others, you have to wear a mask, and then N95 preferably, and monitor your symptoms very carefully. After you test positive, you wait 10 days, you are free from isolation after you test 10 days, because it's at that point in which you are considered not that contagious anymore. So that's the story about isolation. Next. And with regards to quarantine is similar, but it's a little different. It's for just in case. So it's for people who have been in close contact with someone who tested positive. So that person, we don't know if they are positive. So it could be just kind of brewing inside their body. And the idea is that we need to monitor for symptoms and maybe get another COVID test at around 5 to 7 days after your last contact, even if you have no symptoms, because you could still convert. And basically monitor symptoms for 14 days or so. And then if you develop any symptoms, you have to immediately self-isolate and get tested. Quarantine means yes.
Oh, sorry, Dr. Nguyen. There was a question in regards to COVID positive. The question was asked, are there any shortages in Hawaii of the approved COVID treatments that you outlined earlier?
Yes, there are shortages, which is why it can't hurt to ask. You should always talk to your doctor, and they will work with the pharmacist. They have to find a pharmacy which has the drug, or the hospital which has the drug. So there is a supply issue, and so they're trying to save it for those at highest risk. Yeah.
Great, thank you.
Yeah. So so quarantine, highest risk for getting severely ill and for dying. And so anyway, yeah, so stay home, stay away from others, especially stay away from people at high risk for getting sick. And of course, wearing the N95. And of course, you are free again after 10 days after last contact with the COVID positive person, and you have no symptoms. Next slide. So you're probably all wondering about this return to work thing. If you have COVID infection, well, what do we do? I mean, I feel well, I still positive. Can't I just go to work? They need my help. We can't have everybody not working. And so this is kind of the recommendation. So, I mean, the virus never really changed. They still follows its own rules in terms of how infectious it is. So what I described in the last 2 slides is what we call conventional staffing. So 10 days of isolation, and then 20 days if you're immunocompromised, because you don't actually clear the virus as readily, or you can cut it down if you have no symptoms or very mild, or your symptoms are improving, or after 7 days, as long as your test is negative. Keeping in mind that some people continue to test positive for a long time, even if they're not infectious. But if it's negative, then you're clearly free to go. So with contingency planning, contingency staffing, basically, if you're short-staffed and you're still feeling okay, if no symptoms or mild or improving symptoms, go back to work after 5 days. However, if you do go back to work before the 10 days is up, you should wear an N95, face shield, and a gown and gloves so that you don't infect people. But you can work because you're not as sick. And then crisis situation is kind of, last resort. Yeah, there's no restriction, but you better wear your mask, N95 and your face shield and your gown, and go to work and try not to infect anyone. And of course, prioritize those staff who have no symptoms to work. The more symptomatic you are, the more infectious you are.
Hi, Dr. Nguyen. This is Juliana again. There was a question in the chat box. They were wondering what's the difference between sending someone to get tested versus trying to get a test that's not abundant enough to go around. Thank you for that question.
Right now, I think they are sending off, everybody is now able to get the antigen testing, which is going to be free and more readily accessible. So that's actually not bad for a screening test. And I think that that's what we need to go to. But, just have a caveat and try to remember that it isn't as accurate. And so and the only reason why you might want to get the PCR test, which is not as abundant and not as available, but it is important, is for people who you might consider starting treatment on. So those are kind of important, but I think that if it's your antigen test, you should assume
Stop music.
next. Okay, and then this is for somebody going back to work if they are asymptomatic. That means you have no symptoms and you've been exposed. If you've been boosted, if you had the booster shot, you have great antibodies and you have no restrictions. You can go to work with the negative test, even if you've been exposed, because chances are you were like Teflon. You didn't, not likely got the Omicron. If you are vaccinated with 2 or unvaccinated, you don't have Teflon. And if you are exposed, you still might get the COVID. And so you would need to monitor your symptoms very carefully and return to work after 10 days of observation. But of course, if there's staffing issues and you do need to go to work, of course you can go to work, but make sure that you need to test at day 1, 2, 3, and again at between days 5 to 7, because I've had situations and scenarios where one person in the family tests positive and everyone else tests negative, but if you test them again at day 2, 3, and then 5, at some point everyone in the family turns positive. So you have to be very careful, because exposure often leads to infection, especially if you're in the same household. And so you have to be very careful about that. And then of crisis, of course, you have to work and you just have to make sure you wear your PPE so you don't spread it to other people. Okay, do we have any more questions on this COVID? Okay, we'll
None in
move
the
on.
chat box.
Yeah, make sure you use that chat box. Don't be shy. And of course, I again highlight, no social isolation. We don't want to stop friends and family from visiting, regardless of vaccination status, but we can take measures to stay safe. So outdoors, mask, 6 feet, wash your hands and everything like that. Just don't visit if you're COVID positive, or having an outbreak in the facility, or you're sick. And of course, if people come to visit and they refuse to wear a mask, they cannot stay. So just make sure you take measures to stay safe. Okay, move on. All right, so now we're up to the section where we're going to be reviewing and sharing. So I really want you to share your challenges and your cases. Please chat them privately to Juliana Caldwell, and she will read out your questions. So yeah, here's a quick review. This is, remember that we talked about social isolation can lead to loneliness, and loneliness can lead to depression. Next slide. And depression can lead to a whole host of problems like weight loss, physical decline, cognitive decline, and even earlier death. This is why we want to hit it upstream and be on the lookout. Next slide. We talked about how to do a PHQ-2, if you remember, and if you have challenges or questions about what is the best way to do your PHQ-2, then we want you to be able to share that. Has anybody had any trouble doing a PHQ-2 or found it to be challenging to ask residents about this? Please feel free to chat in the chat box. Has it worked out that were you able to do it for people who had dementia or couldn't answer your questions? Didn't want to answer your questions?
Yeah, that was one of the questions. How do they assess for the PHQ-2 if the member is unable to verbally respond?
Okay. So how do other people here do that? Anybody? You can feel free to chat in the chat box. Body language.
Body language.
Body language.
Yes, body language.
Mm-hmm.
How interaction with the caregiver.
Mm-hmm. Right. Right. They're not, in fact, a lot of them are not going to tell you that they're feeling down or depressed, right? It's kind of a taboo thing. You don't talk about that stuff, right? But you observe them, and what do you want? You're looking out for other signs. What other signs are you looking for?
I'm also looking at loss of appetite because it shows loss of interest. It's called will to thrive. So that would be the first thing for me.
Yeah, the will to live, right? They always keep saying, oh, better I make, I want to die, right? Things like that. Oh, look for smiles. That's right. Do they smile anymore? Or are they smiling more now that we started the antidepressant, right? And Lucas says, increased frustration, withdrawal, reactivity, anger. Oh yeah. How about what they were like already? That's really important to look at too, right? Got to get the story from everyone. And of course, I'm going to also invite, anybody can chat. Yeah. But this document can also feel free to chat as well and unmute and chime in. What's the best way to do your PHQ-2? Yeah. Maybe they're just baseline miserable. Is that what you're saying, Rowena? Well, it's possible, but I'm not quite satisfied with that. I really want to see them smile. Some people take that on as a challenge. Can I make them smile, right? Yeah. Smile, yep. Oh, mine sing, that's right, looking for singing. That's right, looking for singing, smiling, or eating. Those are good things to look for. Good. How have you been sharing this with your doctor? Have anybody been able to share this with their doctors, resident doctors?
There was a question, Dr. Wen, that they missed the intro to the PHQ-2. How often do we need to perform this assessment?
Oh, it's just a screening tool. So just screen it every so often. And then maybe quarterly would be good.
Yeah, this is Steve. I think it depends a lot on the particular member or resident. And someone had mentioned in the chat that what if it's someone that had been there for a while? So after you have a resident, you kind of get used to the way they are, even if they tend to be grumpy, right? Then you just look for changes to their grumpiness, if you will, okay? Things like that. But you can, you should be really, particularly now with COVID, this is the focus here is the changes due to COVID, right? So your observations are kind of ongoing. And particularly for folks that are nonverbal or don't communicate really well, someone had put in here about looking for smiles. And of course, people show their emotions with their face a lot of times, right? So you can read people's face and get a good judge for how they're feeling or what their mood is like. So I agree. You don't have to do a formal, documented PHQ-2 every day or every week, but you're doing observations ongoing. So whatever notes you keep or however you keep track of stuff like that, you're just kind of noting, how the person is and what your observations are.
Yeah, and as it was actually in the introduction slide to for the depression and loneliness, right? That we had this little picture of Eeyore, and he says, "Pooh, thank you for noticing," right? Because oftentimes it's the quiet people who don't get noticed. They don't make any trouble at all. They're just very quiet, and they don't do anything, and they don't. So those are the people who get.
That's very true. Yeah, that's very true. Very true. And they can easily just kind of sit in the corner, and they could be really feeling miserable, but they're not really engaging, and they're easy to overlook because they're quiet, and they're not a quote unquote they're not a problem, and so that's something to pay attention to as well. Thank you for that. That's great.
Well, Rowena is a music lover. Music sets the soul free, and that's true. It does. It's one of the most effective behavioral activation kind of a thing, a strategy. Have you guys tried sharing the PHQ-2 with the doctor? Has that worked?
No, I don't want to start to Dr. Wen, because he might start probing, and he gets very personal.
Huh?
The doctor gets very personal.
The doctor gets personal. Oh dear. Are they concerned about the residents? Or maybe they can just do their own evaluation, or?
No, it's like, okay, so what he's been eating, they'll ask, like, maybe he should try, they'll try to strategize more rather than looking at the whole picture and looking for depression and any psychological changes. It's more like they'll say, is he eating? Maybe you should try, if he's not eating, you should try eating the kind of food that, try to. Yeah, so it's hard for them to understand because they don't look at it the way how I wanted them to look at it.
Oh, well, I think if you just tell them they're just not eating, then of course, then they're going to jump to that. But hopefully the providers they should know what a PHQ-2 and a PHQ-9 is. And so if you're able to complete those forms and say, hey, this was my screening, can you, do your own assessment with the patient and see what you think? I don't know.
Because I have one, but then he's not willing to answer because cognitively he's impaired. So he'll just laugh at the doctor. So we cannot assess.
Yeah.
Very hard to assess that.
Yeah. So you're gonna just have to do your own
correct
game plan. So try your own behavioral activation and see if it works. Right?
That's where I'm looking at.
Great. Have you
Yeah.
tried that? Have you tried
Well,
that?
Yeah, well, because of my background from long time ago, we don't want to go that far. um, yeah, I used to do assessment for the little babies,
Uh-huh.
because I used to work for the CPS, and we used to do it's a questionnaire also set to see whether they need special services. These are mostly children that are exposed with drugs and stuff. So we did our own assessment similar to this one. And so you look at their psychological growth, their emotional growth, how they're interacting, how they're developing, and all that stuff. But anyway, I'm sure you know that. And so sometimes I do that with my patient, the one that I am speaking about, and it's easy for me because I had that patient for 11 years now, so I know pretty much his baseline. And so that's why I can see if there is any changes in his likings or his dislikings or any changes on his mood. So I already know that.
Yeah, you guys are really in the best position because you know the residents day in and out, and you see them every day. Yeah. Next slide. So that's why you guys have actually the best chance of coming up with a solution that works.
Yeah, this is Juliana again, Dr. Nguyen. In the chat box, there was a really great point that was brought up about caregivers and their need for help with depression related to COVID and, all the excitement that's gone on these past few years. Thanks for bringing that up.
Yeah, so that's why I talk about, wow, we got to take care of ourselves too.
That is so true, Dr. Nguyen. I know that some of us caregivers are not that verbal in expressing, what we go through, but we go through a lot. And we have to learn to suck it up. I mean, you cannot even show whatever you're going through with your own patient. You just do your thing. And at the end, we end up suffering because of all the stresses that we have. So many stressors that that's upon us, not just COVID itself, but with everything that has to do with taking care of several patients, let alone if you think about family who has to take care of their mom or dad. There's only one patient they have to go through. We go through second and third patient. And it's tough out there. So as far as trying to outlet our own stress, it's very difficult because we can't go out. And it's another stress to that when we try to go out, you have to pay another substitute to go out. And if you have all Medicaid in your care, we don't, well, you know the story already. We don't get paid enough. And to pay someone who is $15 or $18 an hour, and here we only get paid $40.16 a day, and you're paying somebody who is like $90 for 5 hours. It's another stress itself, and it's very depressing to know that you have to spend that kind of money in order to have your little bit of freedom. That's the big stress.
So we got to band together, right?
Yes.
You got to band together and do something. You got to help each other out.
But hearing
this
you
is
alone
Steve again.
and having you to come and help us with this and allow us to express our thoughts and thinking is a big thing. And we're just grateful for that, Dr. Nguyen.
Wow. Next slide, actually. I just want to move on to what do we do? Like when things are rough, right? And so I know somebody mentioned, right, the doctor doesn't quite get it, that the person's depressed, and besides they don't talk, and so they got dementia, so it's really hard to like make a diagnosis. So what do you do? And then what do you do for yourself even? Maybe just trying a gentle and respectful approach, even to yourself. Can you be gentle with yourself, right?
Steve, do you have any suggestions from your point of view?
Well, I was going to say on the issue of caregiver burnout that sometimes when we're in these positions where, we're really responsible to provide care for other people, we can tend to kind of turn off our awareness of our own state of being and how well we're doing, or we feel like, we kind of have to soldier through, if you will, even if we're feeling bad. And so it is important to take time to reflect on how we're feeling as well, and can, ask yourself those two PHQ questions. Are you still engaged in activities that are of interest to you? Do you take time to engage in things that you find pleasurable, and do you take time to kind of take care of yourself? And it's important to do those check-ins. It's as important to do those check-ins for yourself as it is with the residents that you work with on a daily basis. Particularly if you have residents that are, really kind of, I don't want to say a heavy burden, but if they take a lot of care and a lot of attention, we can find ourselves giving until our cup is empty, and we have to be able to refill it in order to have something to share with other people.
Yeah, do we have strategies to, this is challenging. So I'm going to ask Steve and Lucas,
It is.
what are your strategies for taking care of yourself while you can't get out of the situation? You are in the home, that's your environment. You can't get out. How do we make the best of the situation? How do we, what are some strategies to make the best of that?
This is Lucas. I think it's so tough, as everybody has mentioned, and it's hard to make more than 24 hours of the day and still have time for sleep. And adding things is so hard. I think it's hard for a lot of folks to acknowledge their own struggle sometimes, because it feels like admitting like I'm weak or I'm not strong enough, and yet that's not the case. And talking, seeking help, support for caregivers can be an important thing in figuring out what I can change in what I do. And all the basic the oldest medicines are still the best, rest and exercise and social connection, and having meaningful, engaging, valued actions, but so not easy. So acknowledging it and maybe seeking help could be something important to do at some point.
Yeah, don't be so hard on yourself, right? I see.
Yeah, there's a lot in the chat box. There's a lot of people water their plants and garden, and they like to watch movies. Some have fish tanks to help reduce stress, or maybe ponds. And then there was an issue that was brought up in a private message, and I'd like to share that. A person tried her best friend's approach for her client. However, the client became very clingy, and she feels she can't have her own space now, as she would like to be with her all the time. The client is unable to entertain herself and wants to be with somebody. How does she kind of detach while still monitoring and get the rest she needs while still providing that person-centered care to her client? Great question. Thank you.
Right, and as always, the tough questions go to our specialists, Steve and Lucas. Take them out 2 or 3 times a week just for a ride and eat out. The other thing that I found when we did like Namaste Care or music therapy is that sometimes when you do that, you get them started on the right foot at the beginning of the day. The rest of the day, may go better. If you get started on the wrong foot, like you get out of bed on the wrong side, right? It's just impossible to catch up. That's one of the things that I've noticed. And so I don't know if,
Yeah, I like that, Dr. Webb. That's a great approach, is to really from the get-go, from breakfast on, just kind of start with a really positive frame of reference, and maybe sharing something, with everybody in the morning, telling a short story, some way to kind of start the day off with a really positive aspect. And sometimes throughout the course of the day, one of the things that I find very helpful, I work from home and I'm stuck in the house all day. There's nobody here. And so I have kind of the opposite effect, right? I don't have anybody to really interact with. And sometimes throughout the course of the day, I just open the door, step outside, stand in the sun for a few minutes, feel the breeze, breathe in some fresh air, and kind of rejuvenate myself, and then kind of go back in and, sit at the computer and pound away at the keyboard for a while. And the same thing is true if if you have a lot of pressure on you and you're having to, answer the demands of a lot of other people, periodically through the day, just take 5 minutes to go outside, stand in the sunshine, feel the breeze, give yourself a big hug, and take a few really good deep breaths of fresh air, and then go back in, and you're recharged for the next hour or two.
John, can you just forward the slide to the grape slide and just leave it up there so that people can just look at? Yeah. So Lucas, this is fantastic. I just love this GRAPES acronym. And so this is just some stuff to try for helping with depression, right? Making sure you include some of this every day for yourself and also for your residents.
There was a great suggestion in the chat box for clingy clients, iPads to listen to old music. And then there was another suggestion, taking them out a few times a week for a ride, and then eating out when they can. Those are great suggestions.
One challenge that a lot of caregivers face is that when they, you have so little time, but when sort of like a unsuspected chunk of time presents itself, like your clingy person falls asleep unexpectedly, then you're like, oh my gosh, I have maybe 15 minutes. Of course, you might have 50 other things to do, but sometimes in our family caregiver classes, we have, through the Savvy Caregiver program, we have folks keep a list on their refrigerator or in their pocket about list of like 3 things I can do if I have 10 minutes, half an hour, and then you actually write down a number of 3 specific ideas that you can do that fall into one of these grapes categories. So if you have 10 minutes, you can actually do some stretching or something like that. And that's not much. It's not like life changing, but if that becomes something you do when you have like little piece of time, you already have a list, you don't have to think about what should I do. The more you do those little things, they can shift just the feelings a little bit, which can make a difference.
Dr. Wen, what I would do with someone who is clingy or need a lot of attention is I want to make it more structured. Not so much where, but it would be more time for the caregiver, and put a little schedule. So if that doesn't work, try in a shorter span, where I would use a stopwatch or something, and then maybe in increments of an hour. So you would tell your client to say, I'll be back in an hour, and the clock watch or whatever you call it in her room. And I said, whatever you need, hold it until the time rings, and I'll be back. I think that's what I would do for someone who is very always demanding to be you, or if that person can even at least she can see where that time clock is, and she can hear it, and she can visualize it that, oh, I got 30 more minutes before she's gonna be here, and then I can ask her for this. If she cannot wait, if she's still able to write, if still she can comprehend yet, then, tell her, okay, why don't you write down what you want, and I'll be back in an hour. I would start up with short term and then to longer. So I would go from half an hour to an hour, and then eventually increase that to 2 hours, and so on. So I think that's how I would design it for that particular patient or client.
Oh, that's a good idea. It's like every client is different, right? So some need a different approach than others. So
Correct. So you have to
that's
have a
another
lot of, that's right, Dr. Wen.
lot of tricks up your sleeve.
Yes.
Here's another, I think Joyce, I was reading in the chat. I had a clingy client in the past. I always bring her with me and introduce other caregivers who come to relieve me and say that they are my very close friends. So she can get used to them, and they are happy to be with her too. Then she could let me go. Yeah.
But then to me, Dr. Wen, sorry, but in how I see it is that you're like enabling that behavior, and you're not really taking care of the situation. You're not in control. The client is still in control.
So I think it's going to depend on the client. Some are capable, are able to do that, and some are probably
Correct.
not.
You still want to enforce the independence, but yet, you want to also give that allowance for yourself, that independence.
Mhm. Any other tips from Steve or Lucas?
No, I think that's right on. I think that's great.
One other thing that folks have tried with varying success is to try to, and a lot of these folks, if they have, dementia of some kind, they're not really likely necessarily to learn in a reinforcement way. So it's not, we may have little success or expectation that, our reinforcement or lack thereof is necessarily going to change their emotional responses if they don't have the cognitive capacity of learning and having that reinforcement sort of stick. But some might, so that's different there. But some folks, a lot of folks with dementia or anyone, they like to feel like they're helping, right? And if you can come up with a list of different sort of activities that you say, oh, hey, Auntie, can you help me fold these napkins while I go do this other thing I have to do? You give them like 40 napkins or something, and then you're like, thank you so much. Even if it's not something you need done, even if they don't do it well, even if they do it, kapakahi and everything, sometimes that helps them feel like they're helping you out. They have a purpose in those minutes, and you can disengage, and then they get into that activity somehow. So just a way to help somebody feel like they're doing something for you. Sorting nuts, sorting bolts by size, sorting buttons, doesn't have to be anything that you really need, but it can feel helpful for them.
Yeah. Jobs. Right? Purpose.
Right, exactly.
Great ideas. Yeah. Great ideas. Yeah, John, can you forward the slide? Okay. Next. Okay, so I'm gonna put up Grumpy Cat, right? So I'm sure you have residents who do this, right? They refuse to do activities. What do you do? Anybody have ideas for that? Offer ice cream. Oh, nothing like a bribe, huh? Options. Reframe the activity and adjust the plan. Uh-huh. Yeah, ice cream and rewards work for showers too. Yeah. Small goals, very small goals. Change the environment, right? Maybe outside is better, huh? Great. This is a slide to remind you that it takes a team to get over these bigger hurdles. Sometimes patients are extremely challenging. So you gotta try the antidepressants, try some maybe psychologist helping out, or in addition to the behavioral activation. So you gotta try everything to really help them kind of get over the hump. But there's a lot you can do, right? Most of the treatment for depression is not medicine. It's the grapes, it's the behavioral activation stuff. It's every day doing a little bit of something that gives you pleasure. It's a little bit every day of this positive reinforcement. And that's what we need to do for ourselves. You know, if we're feeling down, we got to do some positive reinforcement somewhere every day, a little bit at a time. And that's what we're going to do for them. We do for us. We do for our friends. So I'm let you keep thinking about cases and stuff. I'm gonna go forward a little bit. Keep going, John. Okay, so I just wanted to remind everybody that the PHQ-2, PHQ-9 can serve as feedback. And so if you do it again after a few months, you can sort of see if things are getting better or not, if you try these different approaches. Next slide. And so here's the big favor. We know that 4 months ago, we asked you to do a PHQ-2 and you shared it with our team, and that was really fantastic. And so what we're going to ask you to do again, now that we've done this 4-month series, is to share the PHQ-2, do the PHQ-2 on your residents again, and figure out, you know, how are they doing? Are they doing better compared to the last time? And so try to screen all your residents again before our next session in February. And what we're hoping for is that all of these scores will improve from the first time, since you guys have lots of tools in your toolbox now, and you're all looking out for you know, people who are lonely and people who are depressed and people who fly under the radar. And you know, we really want to demonstrate that you guys are applying everything and doing a great job. So next slide. So just like last time, there's going to be a little form to complete. And Michaela, I'm going to have you go ahead and share this. Talk about this.
All right, so we're going to do the same process as last time. Here is the link for our monthly evaluation. You fill out the evaluation, one name per evaluation. Everybody that needs a certificate of attendance needs to complete this evaluation. You just put one name on it. When you're done with the evaluation, you're going to get a link to your email address with the link for the PHQ-2. So you'll go to that link and you'll select it and you'll fill out another PHQ-2 evaluation for each one of your residents. On that form, you can put everybody from your house who wants a certificate of attendance on that form and then fill it out for your patients. Don't put your patient name on the form. We don't want to know your patient name, but fill it out for each individual patient. I will sit here with you guys for a little while to walk through it. If you need more help, there's going to be a Zoom link on that email that you get as well. I will be on Zoom tomorrow at 10 a.m. and at 2 p.m. and at Monday at 2 p.m. And we can walk through the evaluation, ask questions about PHQ-2 there. I also know that a few of you have indicated that you would like some Zoom training. If you want to jump in and ask questions about Zoom at that time as well, I'll be on.
Thanks, Michaela. Next slide. Okay, and so I wanted to just throw this out there, you know, this was kind of expressed as a need before we started our ECHO series, and you know, and today I'm really glad a lot of you have opened up and are sharing a little bit some of your challenges. We really want to be here for you and help you. And so if you need more support for behavioral health for your residents and for yourself, please email us and let us know. And we will work with our partners, Aloha Care and United Healthcare, to see what we can do to provide more of that support for you. So please let us know what you think might be helpful and how we can meet your needs and help you be better caregivers. I mean, you guys are already awesome, but I'm saying, amazing. You guys are amazing. You deserve to be supported and to keep doing the really important. It's a very noble work you're doing. Next slide. This is just a thank you for caring. And I want to wish you all Happy New Year. It is a new year. We can make a new start of it. And so we're optimistic that we'll have more really good sessions and times together. So that concludes our session, but if you guys want to stick around, and Michaela will talk to you about the forms and stuff. But yeah, and I just want to say thank you to everybody for contributing and sharing all your ideas. It's not always easy to share, so I think it's I really appreciate it.